Good morning, sir. Honorable Chief Guest, respected dignitaries, Head of the Department, professors, and dear students. Good morning to all of you. It gives me immense pleasure and tremendous contentment to be present amongst the esteemed personalities who have won accolades in their respective fields. Today, on behalf of the University Industry Linkage Program and Department of Pharmaceutical Sciences, Guru Nanak Dev University, Amritsar, I, Anshula Mehra, welcomes you all to this lecture on colon cancer and unrecognized threat. Before we get started, I would like to extend a very warm welcome to our Honorable Chief Guest, Dr. Gurbilas Singh, sir, who is a renowned gastroenterologist with special interest in inflammatory bowel disease. With this, I would like to invite Professor Dr. Preet Mohinder Singh Bedi, sir, coordinator of University Linkage Program, to enlighten our audience with the achievements of Dr. Gurbilas.
So thank you, Anshula. A very good morning to all of you. So first of all, I would like to welcome all the esteemed audience, our head of the department, Dr. Balbir, our chief guest, Dr. Gurbilas Singh, my colleagues from the department and other departments, dear students, and ladies and gentlemen. So it's really an honor and privilege that today we have Dr. Gurbilas with us, and he is giving a talk on colon cancer, which is an unrecognized threat by his NGO, that is GI Rendezvous. So before the start of this seminar or a guest lecture, I would like to present Dr. Gurbilas. Dr. Gurbilas is presently working in a Service Gastro City and IV Hospital, and he is a renowned gastroenterologist and a liver specialist. He has got his training from UK after having a basic degree from MBBS and MD from India. So more than a decade he was in UK, and he has a privilege to serve. I just got a information that he has a privilege to serve in Queen Elizabeth Hospital. It's a great honor for us that he is with us. So besides his medical duties, he also gave a number of lectures. He is a social worker and work in the areas of Maja region. So today it's a great honor that he is with us. To no doubt we are having a corona problem all over the world, and we all know that how to now deal with it. But there are other diseases where we have to be a little bit more cautious. And it's an honor that Dr. Gurbilas has accepted our invitation to enlighten the audience that how this colon cancer occur, what are the symptoms, and how we will able to get it prevented by the various methods. Now, before the start of this seminar, I would like to invite our head of the department, Dr. Balbir Singh, who will formally welcome our chief guest, that is Dr. Gurbilas. Now, Dr. Balbir, please.
Thank you, Professor Bedi. Good morning, Dr. Saab. So on the behalf of Department of Pharmaceutical Sciences, a very warm welcome to you to this session. It's our pleasure that you are with us today. Without taking much of time, I invite you to please start your.
Thank you very much for having me here. And very aptly put, although Corona is ravaging the world, we should be certainly looking for this, that there are other diseases which also are as important. So I'm going to just start with the talk, and then the plan is to show a small documentary which we have been showing around for the last 3 or 4 years now. We produced it particularly so that we can.
Excuse me, easily... Dr. Saab, there is a sound problem from you.
Can you hear me? Can you hear me?
Yes, sir. Yes, sir. Now.
Yes, sir, you are audible. Please go ahead, please.
Okay. So, as Dr. Bedi was aptly saying that we have to know about other diseases. This one today we are going to discuss is colon cancer. And why does awareness for this particular disease matter? It matters because we can avoid it. Anything that can be, the population can be protected from and can be avoided should be spread. The word should be spread around for awareness, because that's how we can protect ourselves and our dear ones. So I speak on behalf of a few organizations, including GI Rendezvous, which we founded very much here in Amritsar. But then there's a Doctors Academy UK and Servit Gastrocity, which is our service provision arm for GI Rendezvous. And whenever I talk about any disease, there are two things that we run awareness programs on. One is colon cancer, and the other is the liver, the World Hepatitis Day. Very recently, 19th of April was the World Liver Day. So let me just quickly tell you about the ABCD of what we can avoid for a healthy liver. So alcohol for AIDS, alcohol and hepatitis A. B, body weight, that is body mass index, and hepatitis B, hepatitis C, and D for drugs, whether recreational or over-the-counter. Over-the-counter drugs, very, very prevalent, especially in Punjab, in our region. Extremely important to cut this down, because we don't even realize how much damage we are doing to our livers, kidneys, hearts by just taking these medicines without any rationale. And also diabetes. 30% of our population in this region is either diabetic or pre-diabetic, as per a study from Postgraduate Institute of Chandigarh. So it's very important to be aware of this ABCD, which we have to protect our liver from. Coming to the main topic, we have been talking about various diseases, particularly looking after colons and livers, and at the same time, fitness and cleanliness. It's very important. We did a large event last year, which led to many schools joining in for a plogging event. This was for the first time in this region that we asked the children to join us. We didn't mean to, just go and clean the roads on the same day. It was more of an awareness thing that we can all do it. We should all do it. So that was one thing GR Rendezvous did last year, just before the lockdown. And then there are various academic activities which we do for doctors and for various departments, government departments, for example, police and paramilitary and military, all over Punjab and Chandigarh. We have been trying and spreading awareness about these things. Cancer is such a word that it shocks everyone whenever you hear it. Basically, it's a group of diseases. How many organs you have in the body, you can have cancers of each one of the organs. And the main problem here is that the cell growth, we have cell growth all over in every part of our body. Cells keep growing, but when they become uncontrolled and there is no boundary to contain them, they can invade adjoining parts as well as they can spread to other organs. And this is what makes cancer deadly. It's not just contained at one area, it can go and affect other organs. If we look at the cancer data from all over the world, we can very easily see that colorectal cancer is on the number 4 for the entire world. Number 1 remains breast. No doubt we have so many awareness programs for breast. We all know about prostate cancer. I mean, we're supposed to. And the lung cancer is a big killer. So these 3 cancers, they are most people are aware of because of the worldwide adverts about protecting yourself and being a non-smoker. All those things have made these 3 cancers, people are very aware of them. But the colorectal cancer, nobody talks about. And there are other cancers which we know very little about. Just to refresh our memories from our old school days, the green bit is what we're going to talk about. What we see in the green there is the large bowel or the colon. What we need to know just before we start, that anybody walking in the street, as per the data from UK, US, if 20 people are walking there, one of them sometime in their life will have colon cancer. So it's not that uncommon in that region. We also must know that it is probably the second leading cause of cancer deaths, at least in US, because they have a firm data. They have all the data, so they can talk about this. In India, it's very difficult to collect it at this stage. So we can't talk about Indian data in the context. So also, they have a very robust program in US wherein they offer colonoscopies, that are a screening program for colon cancer, in which anybody who's over 45 is asked to enroll in the program, and they have tests so that we can catch this cancer or the precancerous lesions quite early. But even from their data, they say about 30% of their population who should go for this is probably not going really, either because of the infrastructures, the service provision, or voluntarily not going. So almost 30% people are still not convinced enough to go for this. Just a representation of how it appears when you open the tummy. So symptoms of colon cancer are pretty hidden actually. You cannot talk about is there something like unexplained weight loss, fatigue and vomiting. And it can range from normal symptoms, which everyone has every day, like bloating, gas, pains, fullness, or cramps in the tummy. But then there are some alarming symptoms. Weight loss is one of them, but then presence of blood in the stool, that no one ignores. You know, if we look at it, then that should worry us, and we should always see a doctor for that. Change in bowel habits is the other thing. You're having normal bowel habits, and then suddenly you become either you have constipation or you have diarrhea, something like that. Whatever changes, that needs to be looked at. Now, I just wanted to give a little bit of a scenario where what we do in UK and what is being done in India. It's not to criticize anybody, but it's just to tell us that how we can make things better. So I was working in UK for almost 11 years, and then rectal bleeding, if a patient sees this, he goes directly to his general practitioner. Once he's there, he's assessed there and then, or he's given an appointment to visit the hospital after he's had some routine blood tests. This is actually a very robust system with forms. A GP would tick box, and anybody with a rectal bleeding would have to be seen in a gastroenterology clinic, endoscopy clinic, within 2 weeks of the referral. That's binding on the system. Also, generally the diagnosis is promptly made, and a patient can go back home the same day when seen by the gastroenterologist or the physician. Whereas in India, I've almost worked here for a decade now, and I've seen we all want to hide this symptom. I'm sorry if it sounds a little absurd. We are talking about bleeding from the back passage this morning. So, you know, we should not be shy about it. We should not be feeling, there's no revolting feeling in this, because this is us, this is our body. We have to understand this. We should not be hiding symptoms. If we have such a symptom, we must discuss it, we must mention it, at least to a doctor. But usually what I'm noticing is, what we notice in our routine practice, me and my colleagues, people hide this symptom from all. And finally, you know, at some stage it goes away, and then there's a sigh of relief until it comes back. When it comes back, you go to a physician. Usually physicians will tell you you'll need an examination, but you dilly-dally. Most of us do that, you know. One dilly-dallies and continues for months like this until finally there is a colonoscopy or some examination done. And at that stage, it may not be, that we have caught something very early. So I can say that as a general attitude, we are non-aggressive towards health-related issues. We let ourselves be run down by diseases, and we are not being active about protecting our health and keeping our health robust. There is lack of awareness, although there are lots of diagnostics and healthcare facilities available. But then this also is because there is a cost at the services, you know, and sometimes that can be a deterrent. A person just feels that's okay, we'll see how it goes. Just a little bit about colon cancer, that it affects men and women equally, no bias there. It is the third most common cancer in the world and the fourth most common cause of death. When I say most common cancer in the world, I mean mostly in the Western world. It used to be that more of Afro-Caribbeans, they were not found to have colon cancer that much as compared to the white population. Similarly, it was a thought that in India or in the Indian subcontinent, this cancer does not exist. Maybe in those days, because of the diet, because of our immune system, because of our general health, this was so. But over the years, things have changed, and now we see Afro-Caribbeans who are living in US for generations, they have developed the same incidence as the white, people living in US. So, is it declining? There is some data from the Western world that yes, colon cancer may be declining, and that is particularly because we are doing this robust system of screening people. So it's healthy individuals who have nothing to do with cancer or any other problem. They are being screened by tests to check if they have anything like colon cancer or any other disease that can lead to it. It's like polyps. In the documentary, we'll talk in the vernacular language about how it should be, how it is, and I will leave all this for them. There are certain risk factors, but I would like to bring to your notice the last three ones here on the screen. So these are regular alcohol, obesity, and smoking. These three factors are a health hazard in everything. So, and these are preventable, these can be changed. And apart from that, there are certain other things, including having a disease like ulcerative colitis, which is more of a, immune sort of disease through which, and easily treated for that matter, it's very easily treated. But you need to have consultations with someone who deals with ulcerative colitis regularly, because there are certain protocols that have to be followed. And similarly, if you have a family history, it's very important if you have a first degree relative, which means either your parents or your siblings, if someone like that has had a colon cancer, it's very important to see and discuss with the doctor. There are certain non-modifiable factors which we can't do much about. So, just keeping that in mind, we have to just be more aware of things and take the bull by the horn, really. And then environmental risk factors include diet, your lifestyle, and all those things. Then there are certain, again, modifiable factors like cigarette smoking and alcohol consumption, as we were talking about obesity as well, so dietary factors. And the diagnosis gold standard would be a colonoscopy, which means a camera test, a long tube with a camera, which is put from the back passage to have a look at the mucosa of the large bowel. Largely, this remains as the gold standard as screening. Diagnosing, even CT scans, MRI scans, and PET scans can help. But what colonoscopy does is it looks at it very minutely, as well as it can obtain biopsies to confirm what exactly is going on. And many times, even for treatment, if there are small polyps which have not really become cancers, they can be removed through colonoscopy. In every talk, I present this picture. This gentleman from Moga, he studied in the UK and then went to US for his research in fiber optics. The internet and the endoscopes, whatever we have today, is because of Dr. Narendra Singh Kapani. He is mentioned as a near miss for Nobel Prize because his work was used a year later by somebody else, and then it became a Nobel laureate at that stage. But Dr. Narendra Singh Kapani passed away at the age of, I think, 95 or so, about a year and a half ago. And a great man, philanthropist, and he's worked a lot for science as we see today. He's also known as the Sikh who bent the light. This is probably the first endoscopy procedure being performed by Dr. Hershowitz in Germany. So in those days, these kinds of scopes were used where we had to look through that little hole, and the light light source came a little later. Also, we were using such scopes until the 90s. And then there was a great advent, and we knew there are better things with video endoscopes. So now we can see it on a monitor. This is a typical endoscopy suite. That's where the trolley in the middle, the bed in the middle is just for the patient. And then there are various things around, accessories that we might need, and an X-ray C-arm through which we can even see the insides, like just an X-ray, So this is a typical well-equipped endoscopy suite. These are our endoscopes, and this is how they're placed in the almirah. Once they are taken out of the box, we don't put them back in the box. That could damage them. So this is how they are placed, and they're just kept like that in the safe environment. This is how we function. We need at least 2 people when we are doing an endoscopy, and at least 1 when we are doing a colonoscopy. So colonoscopy is a very important diagnostic tool, and it is used for treatments as well, as we discussed. It can take 8 to 30 minutes. Longer sometimes if the preparation is poor or some other treatment is required. So half an hour is usually what we say, but it can be a bit longer as well. It needs a special preparation. It is not something that you walk in and have. We generally like to see a patient before we recommend this test, and then we just give them a special preparation to clean the bowel. And it can cause some discomfort. There are countries who give sedation, but in India, generally, we don't offer sedation unless the patient wants it. This is just to show how a polyp, which may be a cancer or may turn out to be a cancer a few years later, and how we can go in and snare it and cut it out. And just as a representation, just wanted to show you this. This is our own data. So this 4 or 5 of us work together in this center in Amritsar. So GI cancers from 2019. When I first came from UK, I was told esophageal cancers are very common here in Punjab. Even as compared to the rest of the population in India, esophageal cancers or food pipe cancer, it's very prevalent in this area. Stomach cancers to some extent, but mainly esophageal. But no one ever recognized colon cancers. That is also because we are doing fewer colons. The more we do, the more we find. So this is the data from 6 months in 2019, where we found food pipe cancers to be 26, stomach cancers around 9, and colon cancers not far behind esophageal. So it is about 20. And they're the average ages that we have mentioned. So what we normally say is anybody over 40 with any symptoms needs upper GI endoscopy to look for esophageal cancer. And anybody over 45 does need a colonoscopy with any symptoms. And this is the 1-year data from 2020. Now, keeping in mind that COVID, we were doing lesser numbers of elective procedures. We were doing only emergencies. But the later half of 2020, we started functioning normally. And as you see here, the esophageal cancers do appear to be many more, like 67, and stomach cancers around 5, and colon cancers around 33. So this is the data from almost 5,000 procedures done last year. So out of 5,000 procedures done, we found these cancers, these many cancers. But it is still worth doing. It is still worth checking, because you should not just let it go. So it is the duty of all of us. The month of March by CDC has been mentioned as colon cancer month. And we usually do these talks, these presentations in March. Because of COVID, because of various things, it has been delayed. So we are talking to you in a little, almost a month after we plan to really. But thank you very much for having us here. Questions will go at the end of the thing. What I would also like to say is another awareness that is required is regarding obesity. So many diseases related to it. Very important to curb this pandemic also. With the end of that presentation, I would like to request if we could play our documentary. And once the documentary is played, we'll be open for questions.
ਕੁਦਰਤ ਦੀ ਸਭ ਤੋਂ ਅਣਮੁੱਲੀ ਤੇ ਕਲਾਨਾਤਮਕ ਬਣਤਰ ਹੈ ਮਨੁੱਖੀ ਸਰੀਰ, ਜਿਸ ਦਾ ਹਰੇਕ ਹਿੱਸਾ ਕੁਦਰਤ ਨੇ ਬੜੇ ਹੀ ਸੁਚੱਜੇ ਢੰਗ ਦੇ ਨਾਲ ਬਣਾਇਆ ਹੈ। ਇਹ ਸਰੀਰ ਹੀ ਹੈ ਜਿਸ ਨਾਲ ਅਸੀਂ ਬਾਹਰੀ ਦੁਨੀਆ ਦੇ ਸਾਰੇ ਸੁੱਖ ਭੋਗਦੇ ਹਾਂ, ਪਰ ਬਾਹਰੀ ਸੁੱਖ ਦੇਣ ਦੇ ਨਾਲ ਸਾਡਾ ਆਪਣੇ ਸਰੀਰ ਪ੍ਰਤੀ ਇਹ ਫਰਜ਼ ਬਣਦਾ ਹੈ ਕਿ ਅਸੀਂ ਇਸ ਦੇ ਅੰਦਰੂਨੀ ਸੁੱਖਾਂ ਦਾ ਵੀ ਪੂਰਾ ਖਿਆਲ ਰੱਖੀਏ, ਕਿਉਂਕਿ ਅੱਜ ਦੀ ਤੇਜ਼ ਰਫ਼ਤਾਰ ਜ਼ਿੰਦਗੀ ਦੇ ਵਿੱਚ ਸਾਨੂੰ ਕਾਫੀ ਚੁਣੌਤੀਆਂ ਚੱਲ ਕੇ ਮਿਹਨਤ ਦੇ ਨਾਲ ਜ਼ਿੰਦਗੀ ਜੀਣੀ ਪੈਂਦੀ ਹੈ। ਤੇ ਇਹਨਾਂ ਰੁਝੇਵਿਆਂ ਵਿੱਚ ਅਸੀਂ ਸਭ ਤੋਂ ਪਹਿਲਾਂ ਜੇਕਰ ਕਿਸੇ ਨੂੰ ਭੁੱਲਦੇ ਹਾਂ ਤਾਂ ਉਹ ਹੈ ਸਾਡਾ ਆਪਣਾ ਸਰੀਰ, ਤੇ ਇਸ ਦਾ ਖਾਮਿਆਜ਼ਾ ਸਾਡੇ ਸਰੀਰ ਨੂੰ ਬਿਮਾਰੀਆਂ ਦੇ ਰੂਪ ਵਿੱਚ ਝੱਲਣਾ ਪੈਂਦਾ ਹੈ। ਇੰਜ ਲੱਗਦਾ ਹੈ ਕਿ ਮੈਡੀਕਲ ਸਾਇੰਸ ਜਿੰਨੀ ਤਰੱਕੀ ਕਰਦੀ ਜਾ ਰਹੀ ਹੈ, ਬਿਮਾਰੀਆਂ ਦੇ ਵਾਰ ਤੇ ਪ੍ਰਕਾਰ ਵੀ ਉਨੇ ਹੀ ਵੱਧਦੇ ਜਾ ਰਹੇ ਨੇ। ਬਿਮਾਰੀਆਂ ਦੀ ਲੰਬੀ ਲਿਸਟ ਵਿੱਚ ਜੇਕਰ ਕਿਸੇ ਬਿਮਾਰੀ ਨੂੰ ਆਮ ਲੋਕਾਂ ਵੱਲੋਂ ਖਤਰਨਾਕ ਮੰਨਿਆ ਜਾਂਦਾ ਹੈ ਤਾਂ ਉਹ ਹੈ ਕੈਂਸਰ। ਆਮ ਵੇਖਿਆ ਜਾਂਦਾ ਹੈ ਕਿ ਕੈਂਸਰ ਭਾਵੇਂ ਛੋਟਾ ਹੋਵੇ ਜਾਂ ਵੱਡਾ, ਲੋਕ ਇਸ ਨੂੰ ਹੈਵਾਨ ਸਮਝਦੇ ਹਨ। ਉਸ ਦਾ ਕਾਰਨ ਇਹ ਹੈ ਕਿ ਕੈਂਸਰ ਬਾਰੇ ਲੋਕਾਂ ਨੂੰ ਜ਼ਿਆਦਾ ਜਾਣਕਾਰੀ ਨਹੀਂ ਹੈ। ਕੈਂਸਰ ਦੇ ਅਨੇਕਾਂ ਹੀ ਪ੍ਰਕਾਰ ਹਨ, ਜਿੰਨੇ ਸਰੀਰ ਦੇ ਹਿੱਸੇ ਉਨੇ ਹੀ ਤਰ੍ਹਾਂ ਦੇ ਕੈਂਸਰ। ਅੱਜ ਅਸੀਂ ਕੈਂਸਰ ਦੇ ਇੱਕ ਖਾਸ ਪ੍ਰਕਾਰ ਦੀ ਗੱਲ ਕਰਨ ਜਾ ਰਹੇ ਹਾਂ, ਜੋ ਹੈ ਕੋਲਨ ਕੈਂਸਰ। ਇਸ ਨੂੰ ਆਮ ਭਾਸ਼ਾ ਵਿੱਚ ਵੱਡੀ ਆਂਤ ਦਾ ਕੈਂਸਰ ਵੀ ਕਿਹਾ ਜਾਂਦਾ ਹੈ। ਕੋਲਨ ਕੈਂਸਰ ਦੀ ਗਿਣਤੀ ਦੁਨੀਆ ਦੀ ਬਹੁਤ ਖਤਰਨਾਕ ਬਿਮਾਰੀਆਂ ਵਿੱਚ ਹੁੰਦੀ ਹੈ। ਇਸ ਦੇ ਨਾਲ ਹੀ ਇਹ ਇੱਕ ਅਜਿਹਾ ਰੋਗ ਹੈ ਜਿਸ ਨੂੰ ਵੇਲੇ ਸਿਰ ਫੜਿਆ ਵੀ ਜਾ ਸਕਦਾ ਹੈ, ਜੇ ਅਸੀਂ ਇਸ ਦੇ ਲੱਛਣ ਸਮਝ ਲਈਏ।
ਅੱਜ ਦੀ ਤਰੀਕ ਦੇ ਵਿੱਚ ਸਾਨੂੰ ਮਹੀਨੇ ਦੇ ਵਿੱਚ 4-5 ਕੋਲਨ ਕੈਂਸਰ ਵੇਖਣ ਨੂੰ ਮਿਲ ਜਾਂਦੇ ਨੇ, ਜਿਹੜਾ ਕਿ ਬਹੁਤ ਜ਼ਿਆਦਾ ਹਾਈ ਇੰਸੀਡੈਂਸ ਹੈ। ਸੋ ਮੇਰੇ ਹਿਸਾਬ ਦੇ ਨਾਲ ਜਿਹੜਾ ਵੀ ਪੇਸ਼ੈਂਟ ਦੀ ਬਲੀਡਿੰਗ ਪਰ ਰੈਕਟਮ ਹੈ ਜਾਂ ਪਿੱਛੋਂ ਲੈਟਰਨ ਵਾਲੇ ਰਸਤੇ 'ਚ ਜਿਹੜੀ ਬਲੀਡਿੰਗ ਹੈਗੀ ਹੈ, ਉਹਨਾਂ ਨੂੰ ਐਟਲੀਸਟ ਇੱਕ ਸਿਗਮੋਇਡੋਸਕੋਪੀ ਜ਼ਰੂਰ ਕਰਾ ਕੇ ਦੇਖ ਲੈਣੀ ਚਾਹੀਦੀ ਹੈ, ਚਾਹੇ ਉਹ ਹੈਮਰੋਇਡਸ ਹੀ ਨਿਕਲਣ, ਬਟ ਇੱਕ ਇਵੈਲੂਏਸ਼ਨ ਜਿਹੜੀ ਹੈ ਉਹਨਾਂ ਕੇਸਿਸ ਵਿੱਚ ਬਹੁਤ ਜ਼ਿਆਦਾ ਇੰਪੋਰਟੈਂਟ ਹੈਗੀ।
ਮੈਨੂੰ ਜੀ ਲਾਈਫ ਦੇ ਵਿੱਚ ਕੋਈ ਪ੍ਰੋਬਲਮ ਹੋਈ ਨਹੀਂ, ਮੈਂ ਬਿਲਕੁਲ ਨਾਰਮਲ ਸਾਂ, ਤੰਦਰੁਸਤ ਸਾਂ, ਸੈਰ ਕਰਦਾ ਰੈਗੂਲਰਲੀ। ਅਤੇ ਮੈਨੂੰ ਤਾਂ ਸਿਰਫ ਪਤਾ ਲੱਗਾ ਜਦੋਂ ਮੈਨੂੰ ਆਲ ਆਫ ਸਡਨ ਕੌਂਸਟੀਪੇਸ਼ਨ ਹੋ ਗਈ ਅਤੇ ਪੇਟ 'ਚ ਅਫਾਰਾ ਹੋ ਗਿਆ। ਉਹ ਫਿਰ ਬੱਚਿਆਂ ਨੇ, ਮੇਰੇ ਬੱਚੇ ਵੀ ਡਾਕਟਰ ਹੈ, ਉਹਨਾਂ ਨੇ ਉਹ ਕਥਾਰਟਿਕ ਵਗੈਰਾ ਦਿੱਤੇ ਲੂਜ਼ ਮੋਸ਼ਨ ਲਿਆਉਣ ਵਾਸਤੇ, ਅਨੀਮਾ ਵੀ ਕਰਵਾਇਆ, ਕੋਈ ਨਹੀਂ ਬਣਿਆ। ਫਿਰ ਅਸੀਂ ਟੈਸਟ ਕਰਵਾਏ ਅਤੇ ਫਿਰ ਸਾਨੂੰ ਪਤਾ ਲੱਗਾ ਵੀ ਇਹ ਤਾਂ ਹੁੰਦਾ ਇੱਕ ਕੋਲਨ ਦਾ ਹਿੱਸਾ ਹੁੰਦਾ ਸਿਗਮੈਡ ਕੋਲਨ, ਉਹਦੇ ਵਿੱਚ ਕੈਂਸਰ ਆ।
ਮੇਰੇ ਪੇਟ 'ਚ ਦਰਦ ਰਹਿੰਦੀ ਅਤੇ ਦਰਦ ਤੋਂ ਹੀ ਵੀ ਮਤਲਬ ਆਖਣਾ ਵੀ ਦਰਦ ਆ ਅਤੇ ਡਾਕਟਰਾਂ ਕੋਲ ਜਾਣਾ, ਉਹਨਾਂ ਨੇ ਦਵਾਈ ਦੇ ਦੇਣੀ, ਗੈਸ ਆ, ਤੁਹਾਨੂੰ ਸੋਜ ਆ, ਇਹ ਬੜੇ ਥਾਈਂ ਚੈੱਕ ਕਰਵਾਇਆ। ਫਿਰ ਕਿਤੇ ਨਹੀਂ ਸੀ ਪਤਾ ਲੱਗਦਾ। ਫਿਰ ਖੂਨ ਘੱਟ ਗਿਆ ਅਤੇ ਖੂਨ ਮੈਨੂੰ ਇਹ ਹੁੰਦਾ ਸੀ ਵੀ ਮੈਨੂੰ ਬਵਾਸੀਰ ਆ, ਜਦੋਂ ਲੈਟਰਨ ਕਰਨੀ ਅਤੇ ਖੂਨ ਆਉਣਾ। ਫਿਰ ਅਸੀਂ ਉੱਥੇ MH ਉਹਨਾਂ ਨੇ ਦੱਸਿਆ, ਫਿਰ ਖੂਨ ਚੜ੍ਹਾਇਆ, ਖੂਨ ਚੜ੍ਹਾ ਕੇ ਅਤੇ ਫਿਰ 15 ਦਿਨ ਬਾਅਦ, 15-20 ਦਿਨਾਂ ਬਾਅਦ ਫਿਰ ਮੇਰੇ ਕੋਲ ਉੱਠ ਕੇ ਨਾ ਬੈਠਾ ਜਾਂਦਾ ਸੀ, ਨਾ ਪੌੜੀਆਂ ਚੜ੍ਹੀਆਂ ਜਾਂਦੀਆਂ ਸੀ, ਤੁਰਦੀ ਹਾਂ ਅਤੇ ਸਾਹ ਚੜ੍ਹਦਾ ਸੀ, ਦਰਦ ਹੁੰਦੀ।
ਪੂਰੀ ਦੁਨੀਆ ਵਿੱਚ ਇਸ ਨਾਲ ਹਰ ਸਾਲ ਲਗਭਗ 6,55,000 ਮੌਤਾਂ ਹੁੰਦੀਆਂ ਹਨ। ਇਹ ਅਮਰੀਕਾ ਵਿੱਚ ਹੋਣ ਵਾਲੀਆਂ ਮੌਤਾਂ ਦਾ चौथा सब तो वड्डा कारण है। कोलन कैंसर कई तरह नाल हो सकता है, जिस विच सब तो अहम है इस दा रिस्क जे कोई परिवारक मैंबर इस तो पीड़ित होवे।
ਡੈਫੀਨਿਟਲੀ ਜੈਨੇਟਿਕ ਇੱਕ ਬੜਾ ਵੱਡਾ ਕਾਰਨ ਹੈ, ਪਰ ਜਿਵੇਂ ਸਕਿਨ ਦੇ ਉੱਤੇ ਫਿੰਸੀਆਂ ਹੋ ਜਾਂਦੀਆਂ ਨੇ, ਇਸ ਤਰ੍ਹਾਂ ਵੱਡੀ ਅੰਤਲੀ ਦੇ ਵਿੱਚ ਪੋਲਿਪਸ ਜਾਂ ਫਿੰਸੀਆਂ ਹੀ ਪੰਜਾਬੀ 'ਚ ਸਮਝ ਲਓ ਹੋ ਜਾਂਦੇ ਨੇ। ਇਹ ਪੋਲਿਪਸ ਹਰ ਸਾਲ ਗਰੋ ਕਰਦੇ ਰਹਿੰਦੇ ਨੇ, ਅਤੇ ਜੇ ਇਸ ਤਰ੍ਹਾਂ ਦੀ ਕੋਈ ਫਿੰਸੀ ਹੋਵੇ ਜਿਹਦਾ ਕਿ ਸਾਈਜ਼ ਇੱਕ ਪਰਟੀਕੂਲਰ ਸੈਂਟੀਮੀਟਰਾਂ 'ਚ ਅਸੀਂ ਮੇਜਰ ਕਰਦੇ ਹਾਂ ਜਿਵੇਂ, ਅਤੇ ਇੱਕ ਪਰਟੀਕੂਲਰ ਮਾਪ ਤੋਂ ਜ਼ਿਆਦਾ ਹੈ, ਅਤੇ ਉਹਦਾ ਕੈਂਸਰ ਬਣਨ ਦਾ ਰਿਸਕ ਵੱਧ ਜਾਂਦਾ।
ਮੇਰੇ ਮਦਰ ਨੂੰ ਇਹ 16 ਸਾਲ ਪਹਿਲਾਂ ਹੋਇਆ ਸੀ ਅਤੇ ਉਹਨਾਂ ਦੀ ਫਿਰ 20 ਮਹੀਨੇ ਉਸ ਤੋਂ ਬਾਅਦ ਰਹੇ। ਜਦੋਂ ਪਤਾ ਹੀ ਲੱਗਾ ਤੇ ਡਾਕਟਰਸ ਨੇ ਪਹਿਲਾਂ ਕਿਹਾ ਕਿ ਕਿੰਨੇ ਕੁ ਬੱਚੇ ਨੇ, ਅਤੇ ਉਹ ਬੱਚਿਆਂ ਨੂੰ ਕਲੋਨੋਸਕੋਪੀ ਕਰਾਉਣ ਦੀ ਲੋੜ ਆ ਇਮੀਡੀਏਟਲੀ। ਅਸੀਂ ਦੋਨੋਂ ਭਰਾਵਾਂ ਨੇ ਕਲੋਨੋਸਕੋਪੀ ਕਰਾਈ। ਉਸ ਤੋਂ ਬਾਅਦ ਡਾਕਟਰਸ ਨੇ ਕਿਹਾ ਕਿ ਤੁਹਾਨੂੰ ਹਰ 2 ਸਾਲ ਅਤੇ 5 ਸਾਲ ਦੇ ਵਿੱਚ ਇਹਨੂੰ ਦੁਬਾਰਾ ਕਰਾਉਣ ਦੀ ਲੋੜ ਹੈ। ਸਕਰੀਨਿੰਗ ਤੁਹਾਡੀ ਚੱਲਦੀ ਰਹੇ, ਫਿਰ ਇਹ ਕੋਲਨ ਕੈਂਸਰ ਤੋਂ ਆਦਮੀ ਬਚ ਸਕਦਾ ਹੈ। ਅਤੇ ਮੈਂ ਪਿਛਲੇ 14 ਸਾਲ ਵਿੱਚ 7 ਵਾਰੀ ਕਲੋਨੋਸਕੋਪੀ ਕਰਾ ਚੁੱਕਾ ਹਾਂ।
ਜੇਕਰ ਜਲਦੀ ਇਹਨਾਂ ਛੋਟੀਆਂ-ਛੋਟੀਆਂ ਫੁੰਸੀਆਂ ਦਾ ਪਤਾ ਨਾ ਲੱਗੇ ਤਾਂ ਇਹ ਆਕਾਰ ਤੇ ਗਿਣਤੀ ਵਿੱਚ ਵੱਡੀਆਂ ਹੋ ਜਾਂਦੀਆਂ ਨੇ ਤੇ ਕੈਂਸਰ ਵਿੱਚ ਬਦਲ ਜਾਂਦੀਆਂ ਨੇ। ਇਹ ਫੁੰਸੀਆਂ ਵੱਧਦੀਆਂ ਹੋਈਆਂ ਸਰੀਰ ਦੇ ਹੋਰ ਅੰਦਰੂਨੀ ਅੰਗਾਂ ਜਿਵੇਂ ਲਿਵਰ ਤੇ ਫੇਫੜਿਆਂ ਆਦਿ ਵਿੱਚ ਕੈਂਸਰ ਦਾ ਫੈਲਾਅ ਕਰ ਦਿੰਦੀਆਂ ਹਨ। ਇਹ ਇੰਨਾ ਖਤਰਨਾਕ ਰੂਪ ਧਾਰ ਲੈਂਦੀਆਂ ਹਨ ਕਿ ਮਰੀਜ਼ ਦੀ ਮੌਤ ਵੀ ਹੋ ਸਕਦੀ ਹੈ। ਕੋਲਨ ਕੈਂਸਰ ਪੇਟ ਵਿੱਚ ਸਥਿਤ ਵੱਡੀ ਆਂਤ ਵਿੱਚ ਹੁੰਦੀ ਹੈ। ਸ਼ੁਰੂ ਵਿੱਚ ਇਸ ਦੇ ਹੋਣ ਦੇ ਕੋਈ ਖਾਸ ਲੱਛਣ ਨਜ਼ਰ ਨਹੀਂ ਆਉਂਦੇ। ਜੇ ਆਉਂਦੇ ਵੀ ਹਨ ਤਾਂ ਮਰੀਜ਼ ਉਸ ਨੂੰ ਕੋਈ ਹੋਰ ਸਰੀਰਕ ਪਰੇਸ਼ਾਨੀ ਸਮਝ ਕੇ ਨਜ਼ਰਅੰਦਾਜ਼ ਕਰ ਦਿੰਦਾ ਹੈ। ਇਸ ਦੇ ਸ਼ੁਰੂਆਤੀ ਲੱਛਣ ਹਨ ਪੇਟ 'ਚ ਦਰਦ, ਜਿਸ ਦਾ ਕਾਰਨ ਆਮ ਟੈਸਟ ਵਿੱਚ ਫੜਿਆ ਨਹੀਂ ਜਾਂਦਾ, ਲੈਟਰਨ ਦੇ ਰਸਤੇ ਖੂਨ ਆਉਣਾ, ਵਾਰ-ਵਾਰ ਲੈਟਰਨ ਜਾਣ ਦੀ ਇੱਛਾ ਹੋਣਾ, ਸਰੀਰ ਵਿੱਚ ਖੂਨ ਦੀ ਕਮੀ ਹੋਣਾ, ਵਜ਼ਨ ਦਾ ਘਟਣਾ, ਹਮੇਸ਼ਾ ਥਕਾਵਟ ਮਹਿਸੂਸ ਹੋਣਾ। ਆਮ ਤੌਰ ਤੇ ਇਹ ਲੱਛਣ ਹੋਰ ਕਿਸੇ ਕਾਰਨ ਵੀ ਹੋ ਜਾਂਦੇ ਨੇ, ਇਸ ਲਈ ਮਰੀਜ਼ ਇਹਨਾਂ ਨੂੰ ਗੰਭੀਰਤਾ ਦੇ ਨਾਲ ਨਹੀਂ ਲੈਂਦਾ। ਪਰ ਜੇਕਰ ਸਮਾਂ ਰਹਿੰਦੇ ਇਹਨਾਂ ਲੱਛਣਾਂ ਨੂੰ ਗੰਭੀਰਤਾ ਦੇ ਨਾਲ ਲਿਆ ਜਾਵੇ ਤੇ ਮਾਹਿਰ ਡਾਕਟਰ ਦੀ ਸਲਾਹ ਲਈ ਜਾਵੇ ਤਾਂ ਇਸ ਉੱਤੇ ਕਾਬੂ ਪਾਇਆ ਜਾ ਸਕਦਾ ਹੈ। ਹੁਣ ਸਵਾਲ ਇਹ ਉੱਠਦਾ ਹੈ ਕਿ ਇਸ ਕੈਂਸਰ ਦੇ ਕਾਰਨ ਕੀ ਹਨ। ਮੋਟੇ ਤੌਰ ਤੇ ਪਰਿਵਾਰ ਦੇ ਵਿੱਚ ਕੈਂਸਰ ਦਾ ਹੋਣਾ, ਜ਼ਿਆਦਾ ਚਰਬੀ ਵਾਲਾ ਖਾਣਾ, ਮਾंस ਖਾਣਾ, ਡੱਬਾ ਬੰਦ ਖਾਣਾ, ਜੰਕ ਫੂਡ, ਸਿਗਰਟ ਨੋਸ਼ੀ, ਸ਼ਰਾਬ ਪੀਣਾ, ਮੋਟਾਪਾ, कसरत ना करना, ਇਹ ਸਭ ਇਸ ਕੈਂਸਰ ਦੇ ਕਾਰਨ ਮੰਨੇ ਜਾਂਦੇ ਹਨ। ਕਿਉਂਕਿ ਸਾਡੇ ਕੋਲ ਘਰ ਵਿੱਚ ਖਾਣਾ ਬਣਾਉਣ ਦਾ ਸਮਾਂ ਨਹੀਂ ਹੁੰਦਾ, ਬਾਹਰ ਦਾ ਖਾਣਾ ਸਾਨੂੰ ਚੰਗਾ ਲੱਗਦਾ ਹੈ। ਅਸੀਂ ਆਪਣੇ ਖਾਣੇ ਵਿੱਚ ਸੰਤੁਲਿਤ ਆਹਾਰ ਦਿਨੋਂ ਦਿਨ ਘਟਾ ਰਹੇ ਹਾਂ।
ਇਹ ਕੱਚੀ ਨਹੀਂ ਖਾ ਸਕਦੇ, ਉਹ ਤਲੀ ਹੋਈ ਖਾਂਦੇ ਹੋ ਕਿ ਮਸਾਲਿਆਂ ਦਾ ਸਵਾਦ ਹੁੰਦਾ ਹੈਗਾ। ਸੋ ਜਿਹੜੀ ਚੀਜ਼ ਮਸਾਲਿਆਂ ਦਾ ਸਵਾਦ ਕਰਕੇ ਖਾਂਦੇ ਉਹ ਬੰਦ ਕਰਨੀ ਚਾਹੀਦੀ ਹੈ।
ਪਰਹੇਜ਼ ਤਾਂ ਮੈਂ ਸ਼ੁਰੂ ਤੋਂ ਬਚਪਨ ਤੋਂ ਹੀ ਬੜਾ ਕਰਦਾ ਹਾਂ, ਪਤਾ ਨਹੀਂ ਕਿਸ ਤਰ੍ਹਾਂ ਹੋ ਗਿਆ ਹੈ। ਮੈਂ ਸਮਝਦਾ ਇਹ ਡਾਈਟ ਦਾ ਹੀ ਹਿੱਸਾ ਵਾ ਜਿਹੜਾ ਕਿ ਸਾਨੂੰ ਖਰਾਬ ਕਰ ਗਿਆ।
ਇਸ ਤੋਂ ਇਲਾਵਾ ਜਿਨ੍ਹਾਂ ਲੋਕਾਂ ਦੇ ਪਰਿਵਾਰ ਵਿੱਚ ਕਿਸੇ ਨੂੰ ਇਸ ਕਿਸਮ ਦਾ ਕੈਂਸਰ ਰਹਿ ਚੁੱਕਾ ਹੋਵੇ, ਉਹਨਾਂ ਨੂੰ ਕੋਲਨ ਕੈਂਸਰ ਹੋਣ ਦੀ ਸੰਭਾਵਨਾ 8% ਤੋਂ 10% ਤੱਕ ਹੁੰਦੀ ਹੈ। ਪਰ ਜੇਕਰ ਕਿਸੇ ਪਰਿਵਾਰ ਵਿੱਚ 2 ਜਾਂ 3 ਲੋਕ ਕੋਲਨ ਕੈਂਸਰ ਤੋਂ ਪ੍ਰਭਾਵਿਤ ਹੋਣ, ਉਹਨਾਂ ਨੂੰ ਇਸ ਬਿਮਾਰੀ ਦੀ ਸੰਭਾਵਨਾ ਵੱਧ ਜਾਂਦੀ ਹੈ।
ਕੋਲਨ ਕੈਂਸਰ ਦਾ ਇੱਕ ਜੈਨੇਟਿਕ ਐਸਪੈਕਟ ਵੀ ਹੈ। ਦੇਖਿਆ ਗਿਆ ਕਿ 5 ਤੋਂ ਲੈ ਕੇ 8% ਤੱਕ ਲੋਕ ਜਿਹੜੇ ਕੋਲਨ ਕੈਂਸਰ ਵਾਲੇ ਨੇ, ਉਹਨਾਂ ਦੇ ਅੰਦਰ ਜਿਹੜਾ ਹੈ ਉਹ ਫੈਮਲੀਜ਼ ਦੇ ਵਿੱਚ ਉਹ ਰਨ ਕਰਦਾ ਹੈ। ਦੈਟ ਮੀਨਸ ਕਿ ਉਹਨਾਂ ਦੀ ਨੈਕਸਟ ਜਨਰੇਸ਼ਨ ਦੇ ਵਿੱਚ ਵੀ ਇੱਕ ਡੋਮੀਨੈਂਟ ਕੰਡੀਸ਼ਨ ਹੈ, ਜਿਹੜੀ ਕਿ ਇੱਕ ਸਕਸੈਸਿਵ ਜਨਰੇਸ਼ਨ ਤੋਂ ਬਾਅਦ ਦੂਸਰੀ, ਫਿਰ ਉਸ ਤੋਂ ਬਾਅਦ ਤੀਸਰੀ ਦੇ ਵਿੱਚ ਉਹ ਆ ਸਕਦਾ ਹੈ। ਦੇਖਿਆ ਗਿਆ ਕਿ ਨੀਅਰਲੀ 95 ਜਿਹੜੇ % ਹੈ ਉਹ ਲੋਕ, ਉਹਨਾਂ ਨੂੰ ਸਪੋਰੈਡਿਕ ਕੈਂਸਰ ਹੁੰਦਾ ਹੈ ਕੋਲਨ ਕੈਂਸਰ, ਜਦ ਕਿ 5 ਤੋਂ 8% ਤੱਕ ਜਿਹੜੇ ਫੈਮਲੀਜ਼ ਦੇ ਵਿੱਚ ਰਨ ਕਰ ਸਕਦਾ ਹੈ। ਜੇ ਫੈਮਲੀਜ਼ ਦੇ ਵਿੱਚ ਰਨ ਕਰ ਰਿਹਾ ਹੈ, ਉਹਦਾ ਮਤਲਬ ਹੈ ਕਿ ਜਿਹੜਾ ਸਾਡਾ ਹੈਰੀਡਿਟਰੀ ਮਟੀਰੀਅਲ ਹੈ, DNA ਜਿਹਨੂੰ ਕਹਿੰਦੇ ਹਾਂ, ਉਹਦੇ ਵਿੱਚ ਕੁਝ ਮਿਊਟੇਸ਼ਨਸ ਨੇ।
ਹੁਣ ਗੱਲ ਕਰਦੇ ਹਾਂ ਇਸ ਕੈਂਸਰ ਤੋਂ ਬਚਾਅ ਦੀ। ਬਿਮਾਰੀ ਦਾ ਪਤਾ ਲੱਗਦਿਆਂ ਹੀ ਜੇਕਰ ਉਸੇ ਵੇਲੇ ਇਲਾਜ ਸ਼ੁਰੂ ਕਰ ਦਿੱਤਾ ਜਾਵੇ ਤਾਂ ਉਨਾ ਹੀ ਫਾਇਦੇਮੰਦ ਹੁੰਦਾ ਹੈ। ਉਂਝ ਤਾਂ ਹਰ ਬਿਮਾਰੀ ਦਾ ਬਚਾਅ ਇੱਕੋ ਹੀ ਹੁੰਦਾ ਹੈ ਕਿ ਉਸ ਦੇ ਕਾਰਨ ਪੈਦਾ ਨਾ ਹੋਣ ਦੇਣਾ, ਪਰ ਫਿਰ ਵੀ ਕੋਲਨ ਕੈਂਸਰ ਤੋਂ ਬਚਾਅ ਦਾ ਸਭ ਤੋਂ ਸਹੀ ਤਰੀਕਾ ਹੈ ਇਸ ਦੀ ਸਮੇਂ ਸਿਰ ਸਕਰੀਨਿੰਗ ਕਰਾਉਣਾ, ਜਿਸ ਨੂੰ ਕਲੋਨੋਸਕੋਪੀ ਦਾ ਨਾਮ ਦਿੱਤਾ ਗਿਆ ਹੈ।
ਕੋਲੋਨੋਸਕੋਪੀ ਇੱਕ ਵਿਧੀ ਹੈ ਜਿਹਦੇ ਵਿੱਚ ਇੱਕ ਲੰਬੀ ਪਾਈਪ ਨੂੰ ਜਿਹਦੇ ਅੱਗੇ ਦੂਰਬੀਨ ਲੱਗੀ ਹੁੰਦੀ ਹੈ, ਕੈਮਰਾ ਹੁੰਦਾ ਹੈ, ਉਸ ਨੂੰ ਅਸੀਂ ਨੀਚੇ ਦੇ ਰਸਤੇ ਲੈਟਰਿਨ ਦੇ ਰਸਤੇ ਅਸੀਂ ਪੇਸ਼ੈਂਟ ਦੇ ਸਰੀਰ ਦੇ ਵਿੱਚ ਪਹੁੰਚਾਉਂਦੇ ਹਾਂ। ਉਸ ਦੇ ਨਾਲ ਅਸੀਂ ਸਾਰੀ ਆਂਤ ਨੂੰ ਬਾਹਰ ਕੰਪਿਊਟਰ ਤੇ ਦੇਖ ਸਕਦੇ ਹਾਂ। ਸਾਰੀ ਪਿਕਚਰ, ਉਸ ਦੀ ਡਿਟੇਲਸ ਜੋ ਵੀ ਨੇ ਉਹ ਸਾਰੀਆਂ ਸਾਨੂੰ ਬਾਹਰ ਨਜ਼ਰ ਆ ਜਾਂਦੀਆਂ ਨੇ। ਇਸ ਤੋਂ ਇਲਾਵਾ ਜੋ ਵੀ ਬਿਮਾਰੀਆਂ ਨੇ, ਜੋ ਵੀ ਉਹਨਾਂ ਦੀ ਆਂਤੜੀਆਂ ਦੀਆਂ, ਵੱਡੀ ਆਂਤ ਦੀ ਜਾਂ ਈਵਨ ਕੁਝ ਹੱਦ ਤੱਕ ਛੋਟੀ ਆਂਤ ਦੀ ਬਿਮਾਰੀਆਂ ਨੇ, ਉਹ ਸਾਨੂੰ ਬਹੁਤ ਜਲਦੀ, ਬਹੁਤ ਥੋੜੇ ਟਾਈਮ ਦੇ ਵਿੱਚ ਸਾਰੀ ਕੰਪਿਊਟਰ ਸਕਰੀਨ ਦੇ ਉੱਤੇ, ਮੋਨੀਟਰ ਦੇ ਉੱਤੇ ਨਜ਼ਰ ਆ ਜਾਂਦੀ ਹੈ ਤੇ ਸਾਨੂੰ ਇਸ ਤਰ੍ਹਾਂ ਦੇ ਜਿੰਨੇ ਵੀ ਡਾਇਗਨੋਸਿਸ ਨੇ ਉਹਨੂੰ ਬਣਾਉਣ 'ਚ ਬਹੁਤ ਹੈਲਪ ਹੁੰਦੀ ਹੈ।
ਐਂਡੋਸਕੋਪੀ ਦੋ ਤਰ੍ਹਾਂ ਨਾਲ ਕੀਤੀ ਜਾਂਦੀ ਹੈ। ਇੱਕ ਹੁੰਦੀ ਹੈ ਅਪਰ ਜੀ ਐਂਡੋਸਕੋਪੀ, ਜਿਹੜੀ ਕਿ ਅਸੀਂ ਪੇਸ਼ੈਂਟ ਦੇ ਮੂੰਹ ਰਾਹੀਂ ਕਰਦੇ ਹਾਂ। ਉਹਦੇ 'ਚ ਮਰੀਜ਼ ਦੇ ਮੈਦੇ ਤੇ ਛੋਟੀ ਆਂਤ ਬਾਰੇ ਸਾਨੂੰ ਜਾਣਕਾਰੀ ਮਿਲਦੀ ਹੈ। ਕੋਲੋਨੋਸਕੋਪੀ ਇੱਕ ਐਂਡੋਸਕੋਪੀ ਦੀ ਵਿਧੀ ਹੈ ਜਿਹੜੀ ਕਿ ਅਸੀਂ ਪੇਸ਼ੈਂਟ ਦੇ ਲੈਟਰਿਨ ਵਾਲੇ ਰਸਤੇ ਤੋਂ ਕੀਤੀ ਜਾਂਦੀ ਹੈ। ਇਹਦਾ ਕਾਰਨ ਇੱਕ ਤਾਂ ਡਾਇਗਨੋਸਟਿਕ ਹੈ, ਡਾਇਗਨੋਸਟਿਕ ਮਤਲਬ ਬਿਮਾਰੀ ਦਾ ਪਤਾ ਲਗਾਉਣਾ, ਤੇ ਦੂਸਰਾ ਥੈਰਾਪਿਊਟਿਕ ਵੀ ਹੈ। ਥੈਰਾਪਿਊਟਿਕ ਮਤਲਬ ਬਿਮਾਰੀ ਦਾ ਹੱਲ ਕਰਨਾ।
ਆਮ ਤੌਰ 'ਤੇ ਅਸੀਂ ਜਿਹੜਾ ਕੋਲੋਨੋਸਕੋਪੀ ਹੈ, ਜ਼ਰੂਰੀ ਨਹੀਂ ਕਿ ਸਿੰਪਟਮ ਹੋਣ ਉਦੋਂ ਹੀ ਤੁਸੀਂ ਕਰਨਾ ਹੈ। ਬਗੈਰ ਸਿੰਪਟਮ ਤੋਂ ਵੀ ਤੁਹਾਨੂੰ ਕੋਲੋਨੋਸਕੋਪੀ ਸਕਰੀਨਿੰਗ ਜਿਹਨੂੰ ਅਸੀਂ ਕਹਿੰਦੇ ਆ ਕਿ ਜਦੋਂ ਤੁਹਾਨੂੰ ਸਿੰਪਟਮ ਨਾ ਹੋਣ ਉਹਦੇ ਬਾਵਜੂਦ ਵੀ ਤੁਸੀਂ ਬਿਮਾਰੀ ਨੂੰ ਪਕੜ ਸਕੋ, ਉਹਨੂੰ ਅਸੀਂ ਸਕਰੀਨਿੰਗ ਕਹਿੰਦੇ ਆ।
ਇਸ ਵਿੱਚ ਲੈਟਰਿਨ ਦੇ ਰਸਤੇ ਸਰੀਰ ਦੇ ਅੰਦਰ ਦੂਰਬੀਨ ਰਾਹੀਂ ਅੰਦਰੂਨੀ ਸਰੀਰ ਦੀ ਜਾਂਚ ਕੀਤੀ ਜਾਂਦੀ ਹੈ। ਕੋਲੋਨੋਸਕੋਪੀ ਦੇ ਜ਼ਰੀਏ ਕੈਂਸਰ ਨੂੰ ਫੜਿਆ ਜਾ ਸਕਦਾ ਹੈ, ਕਿਉਂਕਿ ਪਹਿਲੀ ਤੇ ਦੂਸਰੀ ਸਟੇਜ ਵਿੱਚ ਸਰਜਰੀ ਰਾਹੀਂ ਇਸ ਦਾ ਇਲਾਜ ਸੰਭਵ ਹੈ ਅਤੇ ਤੀਸਰੀ ਤੇ ਚੌਥੀ ਸਟੇਜ ਵਿੱਚ ਰੇਡੀਏਸ਼ਨ ਥੈਰੇਪੀ ਤੇ ਕੀਮੋਥੈਰੇਪੀ ਰਾਹੀਂ ਇਸ ਦਾ ਇਲਾਜ ਕੀਤਾ ਜਾਂਦਾ ਹੈ। ਲੋਕ ਇਸ ਤਕਨੀਕ ਤੋਂ ਵੀ ਜ਼ਿਆਦਾ ਜਾਗਰੂਕ ਨਹੀਂ ਹਨ। ਉਹਨਾਂ ਨੂੰ ਲੱਗਦਾ ਹੈ ਕਿ ਕੋਲੋਨੋਸਕੋਪੀ ਉਹ ਲੋਕ ਕਰਵਾਉਂਦੇ ਹਨ ਜਿਨ੍ਹਾਂ ਨੂੰ ਕੈਂਸਰ ਹੋ ਚੁੱਕਿਆ ਹੈ, ਪਰ ਇਹ ਗੱਲ ਪੂਰੀ ਤਰ੍ਹਾਂ ਗਲਤ ਹੈ। ਕੋਲੋਨੋਸਕੋਪੀ ਰਾਹੀਂ ਇਹ ਪਤਾ ਲਗਾਇਆ ਜਾ ਸਕਦਾ ਹੈ ਕਿ ਵੱਡੀ ਆਂਤ ਤੇ ਕੋਈ ਸੋਜ ਜਾਂ ਇਨਫੈਕਸ਼ਨ ਤਾਂ ਨਹੀਂ ਹੈ, ਤੇ ਜੇਕਰ ਹੈ ਤਾਂ ਉਸ ਦਾ ਦਵਾਈਆਂ ਰਾਹੀਂ ਇਲਾਜ ਕੀਤਾ ਜਾ ਸਕਦਾ ਹੈ। ਇੰਨਾ ਹੀ ਨਹੀਂ, ਕੋਲੋਨੋਸਕੋਪੀ ਬਹੁਤ ਮਹਿੰਗੀ ਵੀ ਨਹੀਂ ਹੈ ਤੇ ਇਹ ਕਰਵਾਉਣ ਲੱਗਿਆਂ ਮਰੀਜ਼ ਨੂੰ ਕੋਈ ਜ਼ਿਆਦਾ ਪਰੇਸ਼ਾਨੀ ਵੀ ਨਹੀਂ ਆਉਂਦੀ।
ਕੋਲੋਨੋਸਕੋਪੀ ਦਾ ਕੈਂਸਰ ਨੂੰ ਫੜਨ ਵਾਸਤੇ ਜ਼ਰੂਰ ਬਹੁਤ ਵੱਡਾ ਰੋਲ ਹੈ, ਪਰ ਕਈ ਹੋਰ ਰੀਜ਼ਨਸ ਕਰਕੇ ਅਸੀਂ ਕੋਲੋਨੋਸਕੋਪੀ ਕਰਦੇ ਹਾਂ। ਬੇਸਿਕਲੀ ਇਹ ਗੱਲ ਸਮਝਣ ਦੀ ਲੋੜ ਹੈ ਕਿ ਕੈਂਸਰ ਨੂੰ ਜਲਦੀ ਫੜਨ ਲਈ ਕੋਲੋਨੋਸਕੋਪੀ ਇੱਕ ਟੈਸਟ ਹੈ। ਇਹਦੇ ਨਾਲ ਨਾਲ ਕਈ ਹੋਰ ਬਿਮਾਰੀਆਂ ਦੇ ਇਲਾਜ ਵਾਸਤੇ ਵੀ ਔਰ ਉਹਨਾਂ ਨੂੰ ਡਾਇਗਨੋਸ ਕਰਨ ਵਾਸਤੇ, ਉਹਨਾਂ ਨੂੰ ਫੜਨ ਵਾਸਤੇ ਵੀ ਕੋਲੋਨੋਸਕੋਪੀ ਦਾ ਇਸਤੇਮਾਲ ਕੀਤਾ ਜਾਂਦਾ ਹੈ।
ਕੋਈ ਤਕਲੀਫ ਹੁੰਦੀ ਹੈਗੀ ਆਪਣੇ ਜਿਸਮ ਦੇ ਵਿੱਚ, ਕਿਤੇ ਵੀ ਸਿਰ ਤੋਂ ਲੈ ਕੇ ਪੈਰਾਂ ਤੱਕ, ਪਹਿਲਾਂ ਨਹੀਂ ਸੀ ਤੁਹਾਡੇ, ਹੁਣ ਤੁਹਾਨੂੰ ਹੋਣ ਲੱਗ ਪਏਗੀ। ਚਾਹੇ ਤੁਹਾਨੂੰ ਨੱਕ 'ਚੋਂ ਰੇਸ਼ਾ ਆਉਣ ਲੱਗ ਪਿਆ, ਪਹਿਲਾਂ ਨਹੀਂ ਆਉਂਦਾ ਸੀਗਾ, ਨੱਕ 'ਚੋਂ ਖੂਨ ਆਉਂਦਾ ਹੈਗਾ, ਖੂਨ ਦੀ ਉਲਟੀ ਆਉਂਦੀ ਹੈਗੀ, ਖੂਨ ਖੰਘ ਨਾਲ ਆਉਂਦਾ ਹੈਗਾ, ਪਿਸ਼ਾਬ ਨਾਲ ਖੂਨ ਆਉਂਦਾ, ਟੱਟੀ ਨਾਲ ਖੂਨ ਆਉਂਦਾ ਹੈਗਾ, ਪਹਿਲਾਂ ਕਬਜ਼ ਨਹੀਂ ਸੀ, ਹੁਣ ਕਬਜ਼ ਹੋਣ ਲੱਗ ਪਈ ਹੈਗੀ। ਸੋ ਇਸ ਤਰ੍ਹਾਂ ਤੁਹਾਡੇ ਕੋਈ ਵੀ ਜਿਸਮ ਦੀ ਕੋਈ ਪਹਿਲਾਂ ਨਹੀਂ ਸੀ ਨੁਕਸਾਨ ਹੋਣ ਲੱਗ ਪਿਆ, ਉਹਦੇ ਵਾਸਤੇ ਕਿ ਡਾਕਟਰ ਨੂੰ ਜ਼ਰੂਰ ਕੰਸਲਟ ਕਰਨਾ ਚਾਹੀਦਾ ਹੈਗਾ।
ਬਹੁਤ ਸਾਰੇ ਮਰੀਜ਼ ਅਜਿਹੇ ਹਨ ਜਿਨ੍ਹਾਂ ਨੇ ਇਸ ਬਿਮਾਰੀ ਤੇ ਫਤਿਹ ਹਾਸਲ ਕੀਤੀ ਹੈ, ਕਿਉਂਕਿ ਕੋਈ ਵੀ ਮੁਸੀਬਤ ਅਜਿਹੀ ਨਹੀਂ ਹੁੰਦੀ ਜਿਸ ਦਾ ਕੋਈ ਹੱਲ ਨਾ ਹੋਵੇ। ਲੋੜ ਹੈ ਤਾਂ ਸਿਰਫ ਹੌਸਲੇ ਦੀ, ਸਕਾਰਾਤਮਕ ਬਣੇ ਰਹਿਣ ਦੀ।
ਥੋੜਾ ਜਿਹਾ ਪੇਨਫੁਲ ਜ਼ਰੂਰ ਹੈਗੀ ਹੈ, ਪਰ ਜ਼ਰੂਰੀ ਨਹੀਂ। ਹੁਣ ਮੈਂ ਆਪਰੇਸ਼ਨ ਕਰਾਉਣ ਤੋਂ ਬਾਅਦ ਮੇਰੀ 2 ਵਾਰੀ ਕੋਲੋਨੋਸਕੋਪੀ ਹੋਈ ਹੈ। ਠੀਕ ਹੈ, ਥੋੜੀ ਜਿਹੀ ਦਰਦ ਹੁੰਦੀ ਹੈ, ਪੇਨ ਹੁੰਦੀ ਹੈ, ਪਰ ਇਸ ਤੇ ਕੰਫਰਟੇਬਲ ਹੋ ਜਾਂਦਾ ਬੰਦਾ, ਕੋਈ ਪ੍ਰੋਬਲਮ ਨਹੀਂ ਹੁੰਦੀ।
ਉਹ ਵੀ ਸਾਡੇ ਵਾਸਤੇ ਵੀ ਡਾਕਟਰ ਵੀ ਰੱਬ ਆ ਸਾਡੇ ਵਾਸਤੇ, ਜਿਨ੍ਹਾਂ ਨੂੰ ਸਾਡਾ ਕੀਤਿਆਂ ਸਾਡਾ ਇਹ ਦੁੱਖ ਲੱਭ ਗਿਆ। ਨਹੀਂ ਤੇ ਜੇ ਨਾ ਲੱਭਦਾ ਤੇ ਫਿਰ ਤੇ ਪਰਮਾਤਮਾ ਹੁਣ ਕਦੇ ਪਰਮਾਤਮਾ ਦੇ ਘਰ ਗਏ ਹੋਣਾ।
ਪਰ ਸਭ ਤੋਂ ਵੱਧ ਜਿਸ ਚੀਜ਼ ਦੀ ਲੋੜ ਹੈ ਉਹ ਹੈ ਆਪਣੇ ਆਪ ਲਈ ਸਮਾਂ ਕੱਢਣ ਦੀ, ਆਪਣੇ ਸਰੀਰ ਦੀ ਸੰਭਾਲ ਕਰਨ ਦੀ। ਸੰਤੁਲਿਤ ਆਹਾਰ, ਨਿਯਮਿਤ ਕਸਰਤ ਤੇ ਤਣਾਅ ਰਹਿਤ ਰਹਿਣ ਨਾਲ ਅਸੀਂ ਇੱਕ ਨਹੀਂ ਹਜ਼ਾਰਾਂ ਬਿਮਾਰੀਆਂ ਨੂੰ ਹਰਾ ਸਕਦੇ ਹਾਂ।
ਜੇ ਕਰੀਏ ਕੈਂਸਰ ਦੀ ਛੇਤੀ ਪਹਿਚਾਨ ਹੋ ਜਾਂਦਾ ਹੈ ਇਸ ਦਾ ਇਲਾਜ ਆਸਾਨ।
So, thank you very much. That's what we wanted to present and show. I would like, if anybody has any questions, we'll discuss it.
Yes, yes, Dr. Saab, thank you very much. That's such a wonderful and very convenient way to see a cancer, that how it can ruin our lives. And the best thing is we should do exercise and avoid smoking, alcoholism, and do the proper exercise. So Dr. Gurbilas has presented his talk in a very lucid and transparent manner. So the house is now open for any questions from Dr. Gurbilas. So you can have the benefit that he is here with us. Any questions, please?
Yes, any question from students?
Morning, sir.
Yes, good morning, Pranav.
सर मैंने सर ये पूछा था सर, इसके ट्रीटमेंट के लिए सर क्या क्या सर कर सकते हैं कीमोथेरेपी में सर? ये सर सर्जिकल ही जरूरी है?
So most of the people would still require surgery, because either we present early or we present late. When it is late, many times it is because the patient is already obstructed. There is obstruction of the bowel, and we'll have to do an emergency surgery or something to relieve this obstruction. On the other hand, if we present early, then it's very easy to just treat it, take it out. Midway, whenever we need chemotherapy or radiotherapy, something like that, that is done sometimes just to downsize the tumor. And many times, even after giving that, we still go for surgery. If we can take it out, yes, definitely. But many patients have palliative surgery. मतलब उन्होंने बहुत फायदा नहीं होएगा, कैंसर रहेगा अंदर शरीर च फैल चुका है, बट ਉਹਨਾਂ ਦੇ ਸਿੰਪਟਮਸ ਨੂੰ ਰਿਲੀਵ ਕਰਨ ਲਈ ਫਿਰ ਵੀ ਕੈਂਸਰ ਦੇ ਸਿੰਪਟਮਸ ਨੂੰ ਜਾਂ obstruction ਨੂੰ ਕਿਸੇ ਚੀਜ਼ ਨੂੰ ਵੀ ਸਰਜਰੀ ਫਿਰ ਵੀ ਹੈਲਪਫੁਲ ਹੋ ਸਕਦੀ ਹੈ. So this is a very delicate decision, because many patients are not in good condition for surgeries. Many patients do not accept surgeries. So this is more of a discussion, a multidisciplinary discussion, where we sit with the radiologist, we sit with the family of the patient, we discuss with the patient. It is not something that just told that kal surgery hai ji, kal kar dange. Yeah, emergency ch kai bari is tarah karna penda, but many times we just have to discuss with various stakeholders, family members, as well as our own specialists, pathologists, radiologists, and of course many times there are comorbidities like cardiac problems, heart problems, lung problems. We have to discuss with those physicians. So keeping a holistic view, only then we proceed in such cases, because the first thing we should understand about medicine, about how we practice medicine, is do no harm. So we try not to do any harm. It is only to help the patient. So whatever can be done for that should be done. Thank you for your question.
Good morning, sir.
Good morning, sir.
One by one, please.
Sir, like you said that if a person above 40 experience some symptoms, then he should go for colonoscopy. But sir, can we detect this cancer even before the appearance of these symptoms by using artificial intelligence? Like sir, we can create a software in which we can enter certain parameters and can detect the possibility of getting cancer in future.
Okay, so presently we do have a modality called CT colography. CT colography is something like a virtual colonoscopy. So you're not really doing a colonoscopy, but it is a CT scan with some special contrast, which shows us the colon in a way you would like to see. But this is a test at a very raw stage right now. The expertise and the sort of infrastructure required for this is not available everywhere. And even in UK, where I was working, we used to do CT colographies sometimes, but the gold standard remains colonoscopy. Artificial intelligence is coming up in a big way. Let's see what it does with us in the coming years. Right now, there are some genetic studies. If there is a family history, even Guru Nanak Dev University does, genetic departments does some genetic studies. Many times we try to tell patients to come to you at the genetics department, human genetics department here, and get their tests done. But somehow patients are also not very keen, and things don't happen the way we would like for research. So that's one thing. I'm very, very thankful to the university, Guru Nanak Dev University, because whatever we do, whether it is a social activity, whether it is this documentary, as you saw, we've always had partnership with the university, and everyone here has been very helpful. Thank you very much for that. I hope I have answered your question. Although I know what you asked me, I'm not expert on artificial intelligence. In due course, what comes is yet to be seen. Right now, the gold standard remains what we are discussing.
Thank you, sir.
Good morning, sir.
Morning.
Sir, can colon cancer show the property of metastasis? That is, it can metastasize to other organs or not?
Yes, certainly. Most of the times when we are ignoring our earlier symptoms like weight loss, low hemoglobin, bleeding from the back passage sometimes, if we are ignoring such symptoms, sometimes when we present, it is already advanced and it is metastasized to other places. Yes.
Okay, sir. Thank you.
Good morning, doctor.
Morning.
Sir, I want to ask that can stage 4 colon cancer can go into remission or it cannot be cured?
When we talk in stages, stage 4 means it's already metastasized. So there have been certain studies where they have shown that colon cancer, when say metastasis to the liver, so in advanced cancer centers, what they do, they take the colon cancer out and they also take the metastasis in the liver out. So that prolongs one's life. It may not cure the cancer completely, it may come back, but with this, it definitely prolongs the life. But these are highly specialized things. They have to be discussed at length with the specialists, with the surgeon, and with the family, because these are big surgeries, and sometimes the cancer can come back within 6 months. So it can be as aggressive as that. It is ultimately a cancer. So we do feel at loss many times.
Okay, sir.
Excuse me,
Thank
sir.
you.
Good morning.
Morning.
Sir, if a person is suffering from type 1 diabetes, so is there any chance for developing this colon cancer?
Now, type 1 diabetes is an autoimmune disease. So there are many other diseases which have predilection for such people, which can happen to such people. For example, celiac disease. We've got in Punjab a very common GI problem, gastrointestinal problem, celiac disease, which is gluten sensitivity or gluten allergy. So there are certain diseases linked to diabetes, but as such, colon cancer is not something which is linked to it. But definitely with your lifestyle, colon cancer is linked. And also, if you have diabetes, your vigilance about your health remains very high. So certainly these people are more vigilant about certain things. They talk about their symptoms more often. In fact, they may be better protected than others as far as these symptoms like bleeding from the back passage, because I have seen people who suffer with chronic disease already, they are very open about things. They talk about it more often and more in detail because they know themselves now. They have read a lot about it and they are more aware as compared to a general person. Colon cancer mainly remains, as you would have seen in the human genetics when Dr. Anupam was speaking in the documentary. He mentioned that it is more of a sporadic disease. So over 90% of the cases, you wouldn't know that they're coming or where they're coming from. But there are about 5 to 8% from genetics, so from their family history. So it is a sporadic disease. It can happen to anybody. That is why we need to be more vigilant.
Okay, thank you, sir.
Good morning, sir. Sir,
Morning.
sir, can gut microbiota disbalance can lead to this colon cancer or not?
So that's a very interesting topic and a very hot topic for gastroenterologists now, gut microbiota. A lot of work is being done on this. Now, if we go back, when we were younger, the first dose of antibiotic given to us probably altered our gut microbiota. So everybody is born with unique gut microbiota. And as far as I understand, the indiscriminate use of antibiotics has killed our gut microbiota. That is why many of my patients who come from abroad, when I was in UK, they were complaining there also that doctors here don't give us medicines. And in India, you just go over the counter, buy any antibiotic you want, buy any painkiller you want. All these things have told upon our health. So whether gut microbiota alteration can lead to any disease, it's well documented. Every disease now can be attributed to it as per what the research is showing. And, cancers, whether it is so, not sure. I will not answer that question here in this forum. But quite clearly, I would again mention this point. The use of indiscriminate use of antibiotics and medicines over the counter has to be checked, at least in our next generation. Thank you.
Thank you, sir. Sir, good morning, sir.
Morning.
Sir, could you please elaborate more on the difference between a polyp and a tumor? I mean, what is your approach on that, and how do you attend those patients? I mean,
okay, so a polyp can be like a small pimple, which can be attached to a stalk or can be directly just like a sessile thing lying there. And it can be in a gallbladder, it can be in a uterus, it can be in your small bowel, food pipe, stomach, anywhere. So a polyp can be just like a pimple anywhere. And when we look at it, we always take a biopsy. We always take a little piece of it and look at it under the microscope. And then we classify it, whether it is a high-risk polyp or a low-risk polyp. Many times polyps in the stomach, they are low-risk polyps. So there are umpteen of them. We see them as adenomatous polyps. And we don't have to take all of them out. It is basically, only those which are high-risk ones which have to be removed after confirming. So in our bit of discussion today in the colon cancer, yes, colonic polyps, if I may say, during our training, it was important that if we have done 100 colonoscopies, we must have found at least 15 people with polyps. So 15% was the polyp detection rate in our unit in UK. So in India, we are doing much lesser colonoscopies, but we are also seeing some polyps, probably much less than 15%. So probably we're not doing enough colonoscopies, or we are not having those many polyps in our country here, in our population. So to answer your question, a polyp is a precursor, could be a precursor of a cancer. In 10 years' time, that polyp can develop into a full-blown cancer. So that is why when we say a patient's, say a parent had colon cancer, it's very important to know what age. So say it was 70 years. So when do we start looking at the patient in question. His father had a colon cancer when he was 70. And this patient who's come to me, a young man of say around 50, what do we do for him? What we advise is one colonoscopy right away, whenever he presents, and then one at least 10 years before his father's age of detection of cancer. So that is what we do for colon cancer. There's a set protocol for this. Once we take a polyp out, we need to we need to make sure it doesn't come back. So pathologists help us with that. When we send the specimen to them, they tell us that yes, the edges are clear. So you've taken the polyp out in enteritis. Many times they're full-blown cancers which can still be removed with the colonoscopy, with snaring them, and hence colonoscopy is a very good technique for treatment as well. I hope that answers your question.
Yes, thank you, sir. So, what are the earlier clinical manifestations if a person is having polyp?
There are no manifestations. That's why it's an unknown threat. That is why we are talking about it, that we wouldn't know about it unless we actually look at them. We do tests.
Oh, thank you, sir.
Good morning, sir.
Excuse me.
Good morning.
Sir, can abdominal wall hernias may also develop into a colon cancer?
Not really, no. Hernia can give you many other problems, but it won't develop into a cancer as such. Sometimes, coincidentally, a hernia can occur because of a cancer. So obviously, a holistic picture would be to check what the hernia is all about, where the hernia is, and what part of the bowel is involved in the hernia. So sometimes the hernia is not visible, but it's still there. Sometimes what we call as intussusception, like simple thing, a bowel comes over the bowel. Many large polyps can cause that, and that can cause obstruction. But whatever health problem we face, it is most important to deal with it as quickly as possible rather than procrastinating and not looking after it. Thank you.
Okay. Thank you, sir.
Excuse me, sir.
Yes,
sir, would
please.
you recommend the use of probiotics and prebiotics in gastrointestinal disorders like ulcerative colitis or inflammatory bowel disease?
What do you know about ulcerative colitis? Do you have somebody suffering with it, or do you know somebody who has ulcerative colitis?
So no, I not currently know, but it's just of interest.
Okay. So ulcerative colitis, basically, we talk about it in a way that there is some immune mechanism in the body, as well as the dietary habits, can bring it out. So your question was that ulcerative colitis and probiotics. Many times our bowel habits, as you see, minor infections also, every time doctor will write probiotics with it. That's also because of the antibiotics that are being used. Probiotics will maintain your normal gut flora. When you have ulcerative colitis, you need specific treatment for that. These other things like VSL number 3, particularly to mention these capsules, because there are all studies, European studies on this, and they are basically probiotics. The main thing here is the mainstay of the treatment is not probiotics, but they will certainly help in some cases. So wherever things are not working well, sometimes we do give a trial of that. Sometimes people respond very well, and we keep them on that. Other treatments can be reduced as well. But the mainstay of the treatment is not probiotic.
Okay, sir.
So I think a lot of questions have been asked, and Gulblas has given them in a very satisfactory manner. So now I would like to invite Dr. Balbir Singh, our head of the department, to finally give a vote of thanks for this guest lecture. Dr. Balbir Singh.
Thank you, sir. So finally, I would like to take this opportunity to express my heartfelt gratitude to Dr. Gurglas Singh. So nicely, he has enlightened us about this colon cancer, what are its symptoms, diagnosis, cure, and what precautions we should take. So thank you for delivering such a wonderful lecture. I'm also thankful to Professor Preetinder Singh Bedi, Coordinator, University Industry Linkage Program. Sir, thank you for your heavy cooperation, and rather you are a key person to arrange this lecture. I'm also thankful to faculty members of Department of Pharmaceutical Sciences and other departments of the university. And a special thanks to Dr. Gurpreet Singh for his technical support. And my big thanks to our beautiful audience, that is our research scholars, our students. So patiently they have listened to this lecture. So once again, we all are very thankful to Dr. Gurpreet Singh. Sir, you have delivered a wonderful lecture, and it's a pleasure you are being with us. And we expect one more lecture in future also. Thank you very much, sir.
Thank you so much. We very
Thank
happily
you.
do anything that is necessary. Thank you,
Okay.
sir.
Thank you.
Lovely. Have a great day. See you then.
Excuse me, sir.